So we'll start out, this lecture is going to be about a 3-year-old boy presenting with ultimate status. Okay.
No, it's okay. This happens every time. You just have to clear it here.
All right, so I just want to thank Dr. Liang, Sharpali, Yo, Han, and Chow for the lecture. So some pre-hospital history and notification. You get this 3-year-old boy brought in by EMS for altered mental status. He was vomiting after jumping off his bed, and afterwards was lethargic. His vitals were 110 over 69, heart rate 140, setting 100%, 98.2. On your initial assessment, the airway's intact, the boy is crying. You hear bilateral breath sounds. The skin is warm, has 2+ pulses, but you note that the child is a little lethargic, GCS of 12. So initial vital signs, heart rate of 140, which is just a little bit higher for the 3-year-old normal, not drastically higher. They didn't report a respiratory rate, normal BP, afebrile, at 9%. So preliminary problem list, we have a confused child, a sleepy child. A child complaining of a headache to the occiput and then decreased GCS. So the initial interventions that they did, they put in an IV, gave the child O2, even though there was no report of the DSATs, placed the child on monitor, put the child on a seat collar, grabbed some labs, and then called a level 2 trauma. So getting more information, they were kind of looking on the notes. There were some discrepancies on what happened, depending on which note you looked at. Sounds like the kid was playing on the bed and may have fell onto the back of his head, and then the mom found him crying. Or there was another note that also said maybe he hit his head on a doorknob. But either way, the mom found the child crying, complained of pain, became less active, 1 episode of vomiting at home, and then 3 in the Not much past medical history, just sleep apnea. Patient was on nebulizers from a respiratory problem, but otherwise no known drug allergies. So the exam, the patient, well nourished, well developed, was crying, had an abrasion to the back of the right ear. Pupils were normal. There was no fluid in the external acoustic canals, no hemotympanum, no Babel sign. JVD, midline trachea, everything was pretty much normal. The HENT, chest cardiovascular, regular rate, clear breath sounds. The abdomen, no great turners, no Collins, was soft, pelvis was stable. No perineal hematoma. In terms of extremities, there were no step-offs. The C-spine, the L-spine, everything was non-tender. Good pulses in the baby. The child was moving all extremities. And the neuromuscular, they noted that the cranial nerves are grossly intact, no sensory deficits. Pupils are 5, reactive bilaterally. So the child withdraws to painful stimuli. They noted that the patient's eyes were closed, not speaking coherently, GCS as well. So differential diagnosis, I guess I'll call it to this audience. What do you think is on your differential? I'm gonna start out with Harry, since we have the 10 fellows all here. Okay, we have, anyone else?
Say like some intracranial trauma, and also C-spine injury.
Concussion.
Based on the mechanism.
Concussion, yeah. So basically you're kind of differential for altered mental status, right? You have a history of trauma, so you want to include those cranial injuries, subdural, epidural. Concussion, which kind of does fall into the injury, the head injury. Hypoglycemia, syncope because it was unwitnessed, maybe some sort of toxic exposure, child abuse as well, seizure, and then maybe some, far out there dehydration. Basically, you guys want to just venture into the altered mental status for a child that had an unwitnessed occurrence. So on reassessment of the child, went to the CT, initially with a GCS of 12, and then when they came back, had a GCS of 8. They noted that the patient had a right gaze deviation, jaw clenching, increased tone in the lower extremities, and non-withdrawing to pain with a heart rate of 70. So it sounds like from when the child went to the CT and came back, had just a change in the mental status. And so any further testing and consultations, I guess, what do you guys want at this point?
So they got a CT already?
They went to CT, yes.
Okay.
Yeah. But I guess if we take a step back, what sort of labs would you have wanted? What sort of consults would you have wanted for this child? And what kind of CTs would you have wanted?
CT head for sure.
CT head, yeah.
I'd get labs, a finger stick.
Labs, finger stick, yeah. And then consults, so possible consult for like neurosurgery, depending on what the CT would have shown. We definitely already called the level 2 trauma code, the lethargy. And so in terms of results, nothing really major, right? Glucose was fine, lights were fine, hemoglobin was fine. The CT head, you know, here's all the little nitty-gritty stuff. Essentially, no intracranial or cervical injury that they identified. So this new problem list, now you have this kid who has a worsened mental status. And so your next problem list, you kind of want to add basically bradycardia, eye deviation. Did the kid have a seizure? You know, what happened? Okay. So what I want to go into is more, you know, discussion about TBIs and what we do with it. And I'll preface mostly it's going to be about concussion because I think it's kind of easy when we get like a TBI with a bleed, you call neurosurgery, just go to them and you're kind of done. But what do you do when we get so many of these kids who come in and there's nothing on the CAT scan? What do you do? How do you advise the parents? So we're going to talk about TBI classification, a little bit of epidemiology, just some numbers, some Pathophysiology on how this happens, and then what do we do? What's the management? So TBI can be separated into 2 different categories: diffuse brain injury and focal brain injury. So diffuse brain injury is going to be the most common, resulting in death. It has to do with this acceleration, deceleration forces. Concussion is considered mild diffuse brain injury, and then diffuse traumatic axonal injuries is serious. So consider it more of like shearing forces due to some sort of impact. Focal brain injury is something a little bit more straightforward. Basically, you hit something, you get a bleed somewhere. So brain contusion, brain hemorrhage, subdural, epidural, subarachnoid. That you're going to see on CT, and then that's kind of like easy just go out. So definition of concussion, what you want to see is basically they have a GCS of 13 or 15, and you're measuring it at 30 minutes after injury, which is not basically something you're going to see, be able to measure exactly at that time. So often, if it's more than 30 minutes, you're going to measure it at that time of injury. Did the child have loss of consciousness for less than 30 minutes, post-traumatic amnesia, and then a transient neurological abnormality? And according to the 2017 concussion in sports group definition, a concussion may be done by a direct blow with a force transmitted to the head. It's a rapid onset of short-lived impairment of neurological function, and that resolves. And then any changes is largely functional, not structural. So you're not going to see this on imaging. And then the range of signs and symptoms may be prolonged. And they used to have, you'll hear things, well, it's a mild concussion, severe concussion. They actually used to have these scales. Everything wasn't standardized, and they actually got rid of grading scales because they couldn't correlate a mild concussion was going to have longer symptoms, a severe concussion was going to have whatever. So they got rid of it. It's just concussion. Well, epidemiology. So TBIs are the leading causes in pediatric trauma deaths. They're estimating 475,000 a year, and then 2,600 TBI-related deaths. Usually it's from falls, MVAs. And then 75% of children with multiple traumas have TBI, and almost 8% of all trauma deaths are associated with TBI. And they're estimating for concussion-wise, the lifetime prevalence may be about 20%. So it happens a lot. In terms of pathophysiology, how does this happen? Like, why do we get these deficits related to a concussion? So initially, you want to think of it as the primary injury and inciting event. Oops. Secondary injury, basically, you have the cerebral blood flow decreases. And so the main thing you want to focus on is how are you brain. If you have increased metabolic demand, hypoxemia, hypotension, that worsens the fusion to the brain. And then you start to have increased neuronal damage because of excitatory neurotransmitters. Next, you have impaired cerebral autoregulation that leads to even more cerebral swelling, which usually peaks before 78 hours. You'll have increased cerebral hypertension, more swelling, and then eventually herniation. In terms of concussion pathway, think of it sort of, again, acceleration, deceleration, rotational energy. The location of wherever the child gets hit is not related to where the symptoms are. Kids tend to have LOC if they're hit from the top of the head, from the front or side. And a lot of that, again, is sheer strain of the neural elements. So what we really care about is treatment and management. For kids, so we're used to a Glasgow Coma scale. That's mainly originally for adults. They actually have one for the peds side, and it's very similar. You have the eye-opening, spontaneous speech pain, but the other verbal response is going to be more geared towards a child. So does the patient spontaneously coo or babble, cries to pain, moans to pain. And then for the motor part, any spontaneous movement, withdrawals to touch, withdrawals to pain, flexion, extension. It's all very similar. Mild is 13 to 15, moderate 9 to 12, severe is less than 9. If you have any GCS less than 12 with a finding, a positive finding on a CT, definitely need to do a neurosurgery consult. And then any rapid worsening GCS, intubate. So some key things about intubation while you're doing it. For a kid, you always want to do a cuff in all major trauma. You can use lidocaine, which has a spherical decrease, minimize increase in ICP. Etomidate is known to be neuroprotective. There's some thoughts that ketamine shouldn't be used, but they found that it can be used as an alternative. Sex is not contraindicated. And then once you've intubated the child, your ventilation settings, the key goal is to maintain a PaCO2 of 35 to 40. You don't want to hyperventilate the child because you don't want to risk cerebral ischemia and decreased cerebral blood flow. A lot of this is to maintain adequate cerebral perfusion in terms of goals. And then remember to do C-spine stabilization. A lot of these kids who come in with TBIs also have prominent C-spine injuries as well. In terms of circulation, again, you want to prevent cerebral hypoperfusion. So your goal is for euvolemia, and you want to avoid D5W, too much free water. You want to avoid that cerebral non-infection. And so things that you want to look out for mainly is you have this kid with TBI and has a decreased mental status. So what's going on? You want to make sure that they're not swelling so much that they're starting to herniate. So what are the steps for brain herniation? I think first you're going to have a headache. Next they're going to start to be altered. So this kid had a headache in the right head, started to be a little bit more lethargic. You're going to have a blown pupil and lower ipsilateral eye, so wherever the blade is. And the reason, so that's a cranial three palsy. If you remember from med school, the parasympathetic fibers run on the outside, so any stress or pressing in is going to affect the dilation of the pupil. So that's going to happen first. The next is you're going to get the ptosis and the loss of the medial flip gaze. Next, you're going to have the cerebral posturing for the child, hemiparesis. The other eye is going to get blown as well. And then you're going to have abnormal breathing. So again, headache, altered, the ipsilateral blown eye, then the ptosis, more posturing, weakness than the other eye as everything kind of gets worse. Your brain's not going to be able to regulate breathing. You're going to have the bradycardia, hypertension, and then respiratory arrest. So on your secondary exam for these children, again, look for altered mental status, vomiting, headache, the Cushing's triad. Also look for any like penetrating wounds, and again, C-spine injuries. The neuro exam, we're going to talk about it again. Pediatric Glasgow Coma Scale, level of consciousness, check the pupils, check for third nerve palsy. Fundoscopic exam, we don't really do, but it'd be nice. Brainstem reflexes, and then response. So for this kid, since the kid had a concussion, we may not see all those bad things with herniation, but what might we see? And the most common symptoms for concussion is vomiting, headache, confusion, gait imbalance, memory deficits, a blank stare, dizziness, slow speech, inattentiveness, emotional lability. So if you see a child have these symptoms, it can be attributed to a concussion. What are you going to do? Your workup's going to be the basic lab workup, the glucose, basic labs. They wanted a serum osmolality, but that's more for like inpatient workups. Coax in case of DIC, again, if the patient's really, really sick. And then in terms of for imaging, CT head, don't forget the C-spine, because a lot of the injuries come with concomitant injuries to the spine, a FAST, and then just depending on the trauma, CT appendicitis, MRI, again, all those more depending on how the patient looks. So how do you know who to image? All right, that's the biggest thing for a child. And so we all kind of know the PECARN. I'm going to just go over it really briefly just on how we use it. PECARN has it for the younger kids less than 2 and then older kids older than 2. Took a look at the article and how they determine these things. First of all, they excluded any child who had a GCS less than 14. So basically, if you have any child with a GCS less than 14, you automatically you can't use this, right? And then, so just to go over PECARN, you have the younger than 2, any altered mental status, which this kid had, not younger than 2, GCS less than 15, and then any palpable skull fracture automatically goes for CT. And then LOC, and history of a non-frontal hematoma acting not normally in the superior mechanism, also CT. And then if none of these things happen, then CT is required. They basically did a study and looked at all of the things that would give you the highest probability of a bleed, some sort of bad outcome. And so these are the ones that they came up with. Severe mechanism, just in case you guys need a refresher. Ejection from MVC, death of another passenger, rollover, bicyclist without helmet struck, fall greater than 3 feet if you're less than 2, greater than 5 feet if you're older than 2, and then head struck by a high impact object. They also excluded kids who kind of just walked into a stationary object. So if you have a kid who just kind of walked into a wall, doesn't really apply here. So some definitions. So the people they look at, again, only with GCS 14 and 15 in 24 hours had trauma. They excluded any penetrating trauma, any known brain tumors, any pre-existing neurological disorders. And then they basically were looking at clinically important TBIs. Basically, what they defined this as was death from a traumatic brain injury, neurosurgery, intubation within 24 hours, or hospitalization of 2 nights with the associated brain injuries. So those are the things that they were mainly looking for, not anything else. And then what they defined as a traumatic brain injury on the CT was intracranial hemorrhage or contusion, edema, traumatic infarct, diffuse axonal injury, shearing injury, sigmoid sinus thrombosis, midline shift or herniation, diastasis of the skull, pneumocephalus or skull fracture depressed to at least the width of the table of skull. So if when you're looking at these kids, you're trying to determine, why am I using PECARN? These are sort of the parameters of which they use them for. So basically 42,000 children looked at, only 9.9% had a clinically significant TBI. Neurosurgery was only in 0.1 of the overall cohort and no child died. And they found that if they use these 6 these criteria, had 100% sensitivity with a negative predictive value of 100%. and in children less than 2, and then for children over than 2, 96.8 sensitivity. So they're getting cash. 96.8 of those with a clinically important TBI, and then a negative value of 9.95. So pretty good numbers. All right. So let's say that the kid doesn't have concussion. He goes to CT, and then you come back and you're like, oh my God, there's a bleed somewhere. What do I do? In terms of what do you do for monitoring, the best thing is you want to measure the fluid, you want to measure the pressure. And so the guidelines suggest that you do ICC monitoring, so full neurosurgery, put in oh gosh, I forgot. Basically, the monitor. You're gonna do a vertical. You're gonna put in the monitor to measure the pressure. Your thresholds. You want to have a goal of less than 20 millimeters of mercury of intracranial pressure, and a goal of cerebral perfusion pressure of less than 40. So target to 40 to 50. In terms of treatments, we think of like hypertonic saline, mannitol, elevation of the bed. What they suggest is a bolus of hypertonic saline, analgesias, but avoid boluses that could make them hypotensive. They suggest the CSF drainage, prophylactic medicines for seizure, ventilation, so don't hyperventilate to make them more ischemic, no hypothermia, barbiturates for seizure if refractory to the original seizure medications, decompressive craniectomy, give early enteral nutrition within 72 hours, and don't give steroids. So if you do have a patient here and there tend to board in your ED or for some reason, you can do these things. I think the most salient thing for us to do is the analgesia, the saline, and then the Keppra, and don't make them hyper. In terms of concussion, so let's say the CT comes back and it's completely negative. Just a revisit of what is a concussion. It's a rapid acceleration. You have signs and symptoms of concussion. There's a standardized assessment. So basically, if you're in sports, a lot of this is in sports and kids, they actually have this, it almost looks like the mini mental status exam. They have different questions, different activities to do, and based on that assessment, tells you whether or not how their neuro exam is. You don't see anything on CT, and there's no other medical diagnosis to explain the symptoms. So that's how you kind of come about and tell the patient, okay, well, most likely, we didn't find anything, but most likely this is a concussion. The only things so what are we going to do? The only things really, you're going to treat the pain, so Motrin and Tylenol. You're going to treat the nausea, so Brand. They might have sleeping difficulties. They suggest melatonin. Remove them from competition if this is sports-related injury. Cognitive and physical rest. We have a return to play and a return to learn protocol, and then a concussion center. So NYU has one. I think we have one because this kid was referred to one after discharge. And then just a little bit about like return to play. So if you're now just going to the child, you're saying everything's okay, probably has a mild concussion, what do you do at home? If it's sports and they're asking, can I go back to sports? You want to make sure, first of all, is that you can adequately return to school. Patient is symptom-free and off meds, a neuro exam, and then baseline cognitive and balance abilities. And it's going to be like a 6-stage process. Your first stage is going to be symptom-limited activities. You're just going to do gradual introduction, daily activities. And once the child has demonstrated that they can do this, you're going to slowly elevate to light aerobic exercise just to increase the heart rate. Then you're going to do a little bit more sport-specific exercise just to add some movement, like running or skating, or just some extra like sports related. So if they do soccer, something a little bit more like that, but non-contact. The next one is non-contact related activity, resistance training, just to get them more familiar back to their sport. And then you go on to full contact normal training, just for the confidence, and then finally return to sport. So you can't skip these steps. This is just some guidance that you give to the parents on how they can get back to their normal activities. In terms of return to learn, they might have some inattentiveness, some memory deficits. Maybe they'll have some cognitive disabilities in school. And so some of it is to provide them a note for school to give them some leeway, give the child a little bit extra time for taking their test, a little extra time to take breaks if they're having headaches, let the child put their head down. So just a little bit of leeway for the child in school because of what happened. So in summary, we talked about the classification for TBI, so concussion versus the other ones, the danger signs, so it's going to have herniation, who to image, PECARN, and then how you dispose the patient. And that's it.
I have like
Yes.
3 comments in the
Sure.
sections. One is with PECARN, you don't have to have what like meetings, but one of the things I think is always really important to understand. It's a algorithm that gives you a percentage, right? There's no, it is really like explaining, it's very important to know the use population, but it's also really important to know that even if you put the screen out, you're still left with, I don't know percentages. That in their group, they still had like 0.02%. 0.02. Yeah, it's like it's not nobody. So you always, if you're the one that is so unlucky to do them. But it's just important to know when you're using the algorithm. And then even when you're at the point of observe versus non-observe, it's it's 1% in the yellow zone and it's 0.02% green. So yeah, even in the yellow zone, like 1% is not a lot. Then you asked an ER physician or any physician, like, would you rather someone have a clinically important traumatic brain injury or just CT? But yeah, and then if you screen in or like you're positive for the GCS level 15 or whatever, I think it's somewhere around, I think 10%. That I'm not as sure about, but I know the other ones are definitely 1 and 0.0. Yeah. So just knowing that, I think about
like 4%. But yeah,
it's 4%.
well, where you should CT automatically is like 4%. It's 0.9 for observed versus CT.
Can you go back to it?
So that when somebody talks to you, well, you for the other side, that they really don't want to do it, or they really don't want the CT, and your red zone is still 4%. So is 4%. It's risk taker versus non-risk taker. What your priorities are. It's knowing all of that. One of the other comments I want to make is as far as, because I feel like a lot of, especially EM, you feel like all this concussion stuff. Well, one is don't forget the PMD, because we kind of skip right over to concussion clinic, but the PMD should be really their first stop. And especially if you don't, because you don't know how long they're going to have symptoms, and maybe they're going to come quickly, and they're not going to have you can't get to concussion clinic because it's over at like whatever it is. Just remember that your PMD should still be the gatekeeper for that, and to be able to understand and do a lot of those individual fires. But by your presenting the parents at that time, even though it seems like, oh my God, I need to talk about what this road might look like ahead of them. It is very helpful because it sets them up to understand, especially at that moment, especially if it's an athlete that wants to go back and play. Like I usually with some of them, I know who wants to go back and play because all these athletes want to play. But if they hear from you in the beginning issues and the potential timeline, this is not a 2-day sit out thing, then they're going to be able to kind of anticipate and go forward. You're going to set up the next physicians that have to see them also for success. Yeah.
I think Dr. Tom makes a good point. People always ask me about concussion, or I even offer it now presenting of the head, because I think with all of the stories and stuff, people are really worried. But I always say a concussion is a clinical diagnosis. It's not something that a CT or an MRI per se. I think it's most important that you follow the primary care doctor. And then I do like this explanation where I say it is normal for them to have like a decreased ability to do their work, or they're more irritable, or they might notice these small changes, including one like your brain is what helps you do your everyday life, and now it's hurting and you're asking it to do more. Like of course it's gonna hurt. And if you keep using something that's already hurt, like it's normal, it's gonna happen. It's just gonna get worse. And so then you kind of do the coaching in the same way when you have any of your games of sports injuries. I want to make sure that you see appropriate amount of rest because I want you to be able to play for the rest of your life and not just for the next few months where you're going to get so injured that you can't play anymore. So yeah, like the counseling about like, I don't know yet, might be good. I know most of the pet fellows went to like children's hospitals, police hospitals, when kids coming in with chronic headaches. So yeah, this is despite low mechanism and you just want to prioritize like, look, there's not a clinically important traumatic brain injury, but I don't know what is going to happen in terms of headaches. Yep.
Yeah, you kind of brought up this like whole pathophys of like brain injury leading to, like loss of autoregulation leading to herniation. My question is more for like the PEM fellows, but is it reasonable or is it possible to have herniation or like severe brain abscess findings? And is that different than like diffuse? So like, could you possibly have herniation from the child and then have those?
If you have herniation, you have to go through the. I think you would. You have to go through the.
Well,
Order to herniate,
They're not adults, they're not animals.
I don't think so. I think the answer is yeah. If you're herniated, okay, yeah.
Like, your regular logic still applies. I mean, sort of funny way, and I don't mean it obnoxious way, but they're different, but they're not that.
but I mean from like generalizing, like have herniation without sort of focus. So like you have from generalizing.
You would say, you see, I mean, you see a lack of differentiation brain like that, right?
Okay, so
Right? And you see the edema, and you see the ventricles, you see all the same. You got too much stuff in the box, and the stuff is squished. And so you see it, even in that sense, when you look at it on TV, it's that this crisp line is something asymmetric. Things are not usually fast. Mobile.
okay, and that generalized diffuse swelling thing as like is it the same clinical entity or?
diffuse axonal injury is the mechanism, like what's actually happening to the neuron. The only way to determine if you have DAI is through MRI. And that's not a clinical diagnosis.
No, it's not a such.
Right. So when they do these imaging studies and they're measuring axonal injury, they're using usually diffusion weighted diffusion tensor imaging, and they're actually measuring what happened to the neurons themselves, were they stretched, were they not, and they can measure that on MRI. Now, whether you have diffuse axonal injury, that's separate whether or not you have clinical symptoms of TB. Does that make sense?
Yeah.
So what's
CAT scan may or may not.
the utility of the CT?
No, CAT scan may or may not.
Of
Evidence, axonal injury, but your patient won't take well.
Yeah.
Really not well.
Yeah.
You've got really nothing to CAT scan.
So the idea is that, like, usually it's like these patients that come in with chronic headaches post some trauma that eventually go and get these advanced MRI imaging to determine the root of their headache. If they have signs of diffuse axonal injury, they can say that diffuse axonal or neurologic damage they can believe was related to that precipitating trauma. That's usually what they use it for. Because it helps them identify why they have the things they have. But clinically, it's more important to know, does your patient have signs or symptoms of concussion or other signs that may lead you to get that additional imaging down the line?
Like, if you think of it as even what we were talking about before, as far as PKA, and so that's a cause of, and if they're going to herniate without herniate, A, you have the clinical signs, B, you do have some on CT just because there's too much in that box. And so female hernia, which is perceived as squished ventricle. That,
Yeah. I was like, when I think of, I guess like when I think about like herniation sector, diffuse brain as like primary.
Yeah,
Because I
absolutely.
think if you come as a vocal collections or something, you're right, that those are the herniations I have, brain. So the idea that you have sort of generalized injury that just has full, yeah, or presence of, I guess was my question.
Yeah. Great question.
Any questions? Any other questions? All right, cool. Thanks, guys.
Thank you.